much for being here. I would like to start my presentation about the promising role of neutrophil CD64 as an early diagnostic and prognostic marker in neonatal sepsis. We're back again to the sepsis subject, but we are going to specify its role in the neonates. As its name implies, it is the sepsis that occurs in the first 4 weeks of life, and as we all know and presented before, it's part of the systemic inflammatory response syndrome, including confirmation or suspected sepsis, which may develop into severe sepsis or septic shock ending in death. Neonatal sepsis represents the most common cause of neonatal morbidity and mortality in the early human life. The WHO has estimated that about 1 million deaths per year is due to neonatal sepsis. And about 42% of these deaths occurs in the first week of life, so we have very short time. 99% of these deaths occur in the developing countries. This is the figures proposed by the WHO, showing that sepsis is about 26% of the cause of death in neonates. However, the rates vary from one region to another, being higher in Africa and Asia and developing countries such as ours, rising up to 40%, and lowest, of course, in the United States and Austria, being 1.5 to 3.5 neonatal deaths per 1,000 live births. Not only, as this figure proves, not only death is the problem, but we also have a very high morbidity among the survivors, including neurodevelopmental diseases, deafness, blindness, and renal failure. So, from all the mentioned data, it is evident that the early diagnosis, follow-up, and proper treatment of sepsis not only increase the survival rate, but also improves the prognosis among the survivors. Here we come to the problem, how to diagnose neonatal sepsis. We have clinical data which are vague, being shared with respiratory and neuro and renal metabolic changes, and the laboratory and radiological methods used for diagnosis, which are very vast and including many tests that could be done. Here I will stress on the laboratory diagnosis of neonatal sepsis. To summarize, it is we put it in 3 categories. First, the isolation of the microorganism. Second is the hematological studies, including the study of acute phase reactants. And third is the new marker of sepsis or the molecular diagnostic techniques, which I will not be discussing in this presentation. Of course, the blood and the bacterial cultures are the gold standard. However, they have many disadvantages, including long turnaround time, up to 7 days, many false positive and false negative due to innate parameters. The CBC parameters itself are a good follow-up markers. However, they are late diagnostic, so they don't serve us in the critical period. They take, in addition, they are non-specific and they vary with many pathological conditions and even with age. However, there remains one marker that's very specific, is the immature to the total leukocytic count that can be helpful in the early diagnosis of sepsis in the neonates. The CRP, as we all know, is the most researchable marker since 1930, and however, it may have many disadvantages of low sensitivity, low specificity, but now we use the high sensitive CRP in our hospital, as it increases the sensitivity to more than 20 times the regular technique. So, to diagnose, we have to use the conventional methods. We cannot neglect them. The new biomarkers, which we are going to talk about, in order to reach a rapid and accurate diagnosis for sepsis. There are many markers that has been researched. However, we selected a few markers to discuss that showed very promising markers. On top of them is our neutrophil CD64, which we are going to discuss today, the neutrophil CD11B, monocyte CD14, monocyte CD163, procalcitonin, persepsin, interleukin 6 and 8, and proadrenaline. The neutrophil CD64, when we come to know what it is an Fc receptor gamma 1 on top of neutrophils, and it helps in the immune mechanism to regulate and to help opsonization and engulfing the pathogens. So in this study, we aim to answer 4 questions. The first, was to evaluate the diagnostic performance of neutrophil CD64 as an early diagnostic marker for sepsis. The second was to compare between its value and its levels and the conventional modalities used in our hospitals. The third was to identify the panel of markers which we can use among the conventional and the new biomarkers. And also the final question that we needed to ask was, does it have a prognostic value in follow-up, and can it be used in follow-up? This study was conducted earlier this year and the late last year, and included 175 evaluations conducted on 121 newborns. 54 of these were follow-up evaluations. We couldn't follow up all the babies because we had mortalities, transformation from one department to another, so these are the follow-ups that we could use. We divided our patient into three main categories. Group 1A, which is the proven sepsis, including 17 patients. They have proven blood culture positive for sepsis. Group 1B, these are the suspected patient group, including 74 patients. They are neonates with clinical symptoms and signs of sepsis, in whom bacterial culture results were not yet available. And the group 2 was the control group of 30 patients which were healthy, age and sex matched neonates. The criteria of sepsis were including, according to the clinical guidelines, they have to include respiratory, cardiovascular, and metabolic changes. All our subjects were subjected to a complete blood picture, and the IT ratio was done for 50 patients to evaluate its value. Blood culture, CRP levels by highly sensitive technique, flow cytometric evaluation of CD64. And I want to talk about the flow cytometry technique. I will spare you the laboratory details because most of you are not laboratorian as I am. It's a very easy technique once you have the machine, especially for the CD64. It utilizes whole blood, doesn't need separation. It utilizes only 100 micron, which is very minimal blood. This is important for the neonates because harvesting blood samples are very crucial problem. When we come to our results, first the comparative statistics as regards the demographic data, all our candidates were matched for age and weight. However, there was significant difference between the symptoms between the control group and the sepsis group, group 1 and A and B, as regard respiratory distress, respiratory support, undergoing surgery, and congenital anomaly and death. When we came to evaluate all our data, including CBC data, CRP, and CD64, we have two parameters given to us by the machine, the CD64% and the CD64 intensity. They were all highly sensitive except for the platelets and the hemoglobin total leukocytic count. The performance of CD64 alone as an early marker, we found that it has a specificity over 90%, sensitivity over 85%, with a total efficiency 87%, which was very promising, not as promising with the CD64 intensity marker. With ROC curve analysis, that we can see that the area under the curve is very high, 0.964, shooting high, which is very promising. So as an early marker, in first 2 days of sepsis, it served to diagnose sepsis accurately, both sensitive and specific. When we come to answer the second question, what about its comparison between it and the other conventional markers? We see that CD64 had higher values in most of the values, especially in the area under the curve in the ROC curve analysis. As you can see, CD64 was the highest marker, followed by the CRP and CD64 intensity, and other markers were way behind. When we come to calculate the Z-score is a statistical analysis test, being higher as an early marker. We also see that it was highest with the CD64% and not the intensity in both the proven sepsis group and the suspected sepsis group. So it helps to differentiate also between the proven and the suspected group, giving us a very sharp demarcation. So we have answered our second question. The third question was what panel to choose. So we did a multi-regression analysis using the SPSS version 22. We did multiple combination to find which combination is the best. The first module, we included all our parameters, and we only found that the CD64% and intensity were the significant parameters, and the others had minimal contribution in the diagnosis of sepsis. So we did another multi-regression analysis, including only the CD64, a constant value, and the CRP. And I will tell you why the CRP, though the CRP here level is non-significant here, but I will tell you why we choose to incorporate CRP in our regression equation to be used. If we use this equation by the clinician, it is proven that it improves the diagnosis of sepsis. Here, when we have the CD64 alone, here when we have the CRP alone, and here when we have the combination, we find that CD64% is deficient in the negative predictive value. It's only 68%. When we add the CRP to it, it jumps up 10% more to become 78%. So the negative predictive value and the overall efficiency is improved from 87% to 93.4. So I think it's important to exclude that the patient, the negative predictive value increases by 10% is very helpful by the CRP, which is a cheap and easy test to be done. So this is the ROC curve analysis showing that this is the combination giving us the highest area under the curve being 0.988, about selecting the test. Both tests will be able to identify 988 of 1,000 patients if possible. So now we answered the third question, which was the best combination to choose to clinical diagnose. What about the final question, its role in prognosis? In our study, we had a death rate of 33%, and we also again calculated the Z-score between outcome 1, continued sepsis in the follow-up, and outcome 2, which is the clinical improvement. And all the parameters were very low in diagnosing continued sepsis or the clinical improvement with dropping down of the level of CD64 with clinical improvement, and CD64 was the highest in both tests. So we still held a more comparative statistic that I will be telling you in the second presentation, supposed to be given by my colleague, the comparison between CD64 and the other markers I mentioned earlier. So to conclude, CD64, it's in our hand to help our neonates to tide up through the neonatal sepsis stage and to go back to their families clear. CD64 is an early, specific, and sensitive marker of neonatal sepsis compared to the conventional markers. CD64 and CRP combination represents the best earlier marker of neonatal sepsis over the conventional methods used in our NECUs. And the serial measurements of infection markers can help us predict the early symptoms and signs and give the treatment appropriately, and also can predict the outcome and the prognosis. CD64 can be easily performed in clinical laboratories once they have the machine of the flow cytometries, which is now available in most labs in diagnosis. In my last slide, I include this photo of our neonatal intensive care unit to tell you that it is very crucial for us to identify neonatal sepsis, because not only we help in saving our neonatal life, not only we help to save their families from the financial and emotional burden, but on the long run we will be able to save our country from the burden emotionally and financially from supporting such families. Thank you so much for listening, and any questions?
Yeah. Thank you for giving this presentation on a new marker for neonatal sepsis. Are there any questions? Yes?
Hi, very nice talk.
Thank you.
I'm aware that you can get soluble versions of CD antigens. Do you know if you can get soluble CD64, and is that worth looking into?
Actually, the technique using the flow cytometry is very easy because it uses whole blood, very minute amount. The turnaround time is about 1 hour, so it's very rapid. And the cost in our country is about 60 Egyptian pounds, which is about 6 British pounds. So it's very cheap. ELISA techniques in Egypt are even much more expensive when we compared with other markets. So the problem is to have the flow cytometry machine, and here you go. So
Okay, but you don't know if you can get soluble CD64.
we didn't try, actually.
You're using Infectious or Becton Dickinson?
Becton.
Yeah.
Yeah.
And you're buying the CD64 from the company itself?
Yes.
It's just a closed system because some CD64 might be slightly different.
We tried this system, and so far it's.
Yeah, you didn't try other antibodies or on.
Excuse me?
You didn't try it with other antibodies
No.
apart from the
No.
kit?
No.
Okay, thank you.
CD64 is constitutively expressed on macrophage and monocytes.
No, it's only on neutrophils. CD14 and CD14, which I'll be discussing in the second presentation, is expressed on the monocytes and the macrophages. So that's the difference between CD64 and CD14b, and that's why it's more promising and more specific.
So have you tried some other marker for neutrophils?
Excuse me? Yes, 11, CD11b. CD11 is a neutrophil marker as well. Wait for the second presentation, and I will give you a comparison between them.
Sure. I mean, I remember that CD64 is constitutively expressed on monocyte and macrophage, and CD11b is a marker for macrophages. CD11c is a marker for dendritic cells.
No. CD64 is the FC receptor gamma 1 on neutrophils only. CD14 is the one expressed on monocytes and macrophages. I'm quite sure. I've just studied that.